Like you rightly mentioned, palliative care as a word seems to be something very new. Though certain aspects of palliative care, whether it's pain management, whether it's taking care of end of life, has been practiced in various forms from many years. Right? The person who's considered to be the founder of palliative care is Dr. Cicely Saunders. After she finished her medicine, she came back and she started the first palliative care center or hospice, which was St. Christopher's Hospice in 1967. And that was the beginning of palliative care as we know it today. And what is it that she did a little different from what was being done? Three main areas. One is she focused on the holistic care of the patient. And what we meant by holistic care is she said we need to take care of the physical, emotional, social, as well as spiritual aspects of the patient.
The WHO definition says palliative care goal is to reduce the symptoms or relief of symptoms and improve the quality of life of not only the patient but the family members, and seeing the person as whole, not as one compartment.
How long does or can palliative care last?
It depends on various factors. For example, we've had patients who've been on palliative care for 10 to 15 years. At the same time, we've had patients who've been on palliative care for a couple of days.
A question for Dr. Carolin. What are the benefits of palliative care?
Yes, definitely when it comes to benefits of palliative care, the angle of psychosocial, spiritual, of what happens to patients as well as their families when there's a life-limiting illness. We look at it as psychologists or as mental health professionals from three aspects.
So, doctor, I wanted to ask, when does one avail of palliative care?
Welcome back to Aging Gracefully, a talk show for evergreens. This is the second part of the episode on palliative care.
Doctor, where can one avail of palliative care?
Thank you for that question. When you talk about where a person goes to avail palliative care, it's very important to understand that access to palliative care in India, for instance, is not more than 5%. And globally, it's not more than 15%. So we look at this question from two perspectives. One is, where's the logical point to start with? Generally, when someone goes to a medical doctor and is told the disease condition and what needs to be done, that would be the first point of contact when you talk about palliative care. And we encourage you all to reach out to doctors and ask them, can we actually be referred to some source of palliative care? Now that the different benefits of palliative care are more obvious to both the patient as well as their families. Right? The second very important thing to understand is palliative care comes in different forms. For instance, you can have a patient being admitted as an inpatient to provide certain aspects of palliative care. Similarly, you can have a patient who comes to the outpatient department for something relatively minor and gets a form of palliative care and goes back home. Thirdly, you have a situation which ideally is what you want to have most of the time, which is home-based palliative care, where the palliative care is provided at home itself. And I think Dr. Carolin has spoken a lot about that and how that can be done. Now, we have a lot of institutions which are relatively well known, many Christian institutions, many non-governmental organizations running institutions where palliative care is provided. And when you talk to the medical care provider, he or she will be in a position to direct you to such institutions. The important fact is to understand that the field of palliative care is continuing to evolve. We have more and more organizations starting palliative care centers, so there will be more access to palliative care. But at the end of the day, when it comes to managing a patient who requires palliative care, the focus is always to try and shift palliative care to the home.
I just want to add on to what John just now said, the access part of it. So when we started the rural palliative care in Baptist, that was like almost 7 years back. So what we understood, we were working in the rural settings and we saw a lot of patients who were going they don't even know that they have cancer, but they're in the last stage. So they have big wounds and, severe pain. We've also found children who are like, howling with pain, and the mother sitting and don't know what to do with it, because you have to take them every 4 hours or 5 hours to hospital, which they didn't have the resources to. So at that point we said, how can we help them? Because for them to come to main hospital or in cities, it is like every day is like 500 rupees, somebody has to bring them, and then next day again to bring. It's not sustainable at all. So that is when we actually started the rural palliative care unit, in which at that time we didn't have resources. So one doctor with 2 nurses and a chaplain will go in an auto rickshaw. Our team usually minimum 80 to 90 kilometers a day travel, and then go to these houses. And even what we are, so if you look back, we're very satisfied, because most people who didn't have any access and had a very miserable state, once we go and give the medication, the next day, it's like everybody is saying that some miracle happened, because the person who's not even moving because of the pain is sitting out and talking to the neighbors. So it's like they even think that it's cured, but it's not cured. They will eventually die. But the access, and also another thing we found is that as a family, that's when they slept together, because because somebody is in pain. If your husband is in pain and they're crying and your child is in crying, you cannot sleep, right? So they're going day in and day out with this kind of situation. So access to palliative care, and palliative care is not costly. If you actually design it in the right way, then when a person is about to die, all our trivialities goes. Very basic. What do you want? You want the presence of your loved ones, symptom control. That's all you want. Nothing else. You don't think of other things. So it is a very simple science, and our average cost for a day, if you see for a patient, it's not more than 20 to 30 rupees. So we are able to do, and that's how now we start from one taluk. Now we are catering to 2 districts of 2.5 million. So I just wanted to add a bit about the access and how important it is.
I'm glad you brought in this dimension, that it is practical, but it is also economical. Because sometimes people think that the only arena where you can get this care is a high fancy hospital which has all that equipment, when you don't even have the resources for that. Because that brings in, therefore, an ethical issue. Because there are some hospitals that will not have palliative care because they want you to go in for the aggressive treatment. I'm not saying all, but even if there is one, it's just too much. Because the concern is not about the care of a patient, but a purely profit-making endeavor. And so it is in the interest of the business interests to make sure that palliative care doesn't get the larger setting or the greater acceptance that we need. That's why I'm so happy that in conversations like these, we get a chance not only for ourselves, but to spread the word to others, to share this link with others, so that they begin to see that this is a dimension that's rather new, as you rightly pointed out, 1967. But I think it needs to be heard much more and embraced much more, because it ties to the holistic development. And just think, when so many people are so poor, they just cannot afford or have access, simply because, as you put it, just a visit to the hospital and back, just the transport visit, how much more will the cost? So, and it is these things that really cry out for palliative care to become much more accessible, and the knowledge of it as well, so that more and more people will avail of something that will enable them to come to the first point, to live their lives with dignity and a wonderful quality of life. In other words, even as they are dying, they still really live. And I think, thank you for that perspective.
Thank you, Father.
And on the same lines, Father Juvie, it's very interesting to see that a lot of corporate hospitals now have pain and palliative care departments, right? And that comes back to the fact that for pain management, like Dr. Carol mentioned earlier, at some stage you have to start using opioids like morphine. And it's very difficult to get access to such medication because of very logical reasons. The important thing is, when you look at palliative care and the way which has been described by this panel, you realize that at some point of time, the cure stops, the cure ends, but care does not end.
Yes.
Love does not end. The relationship you have with your loved one does not end, nor do the memories. And I think that's where palliative care, the essence of palliative care comes in and allows you to have those happy memories even after they leave you.
I also want to add one more thing. Yeah. So, one of the things that when corporates or, as Father Juvi said about when profit-driven institutions come into the picture, there's also a tendency to expand the definition of palliation in terms of saying that aggressive treatment can be part of palliation, So that is also another dimension that we have to be very mindful of, because we have had the experience, even the Cicely Saunders. So we started palliative care in Baptist very early, and even Dr. Stan, who started it, had interactions with Dr. Saunders, and also Robert Twycross, the stalwarts, and the first nurse, palliative care nurse, the Gilly Burns. Everybody, we've been like their philosophy is. Its palliative care is simple and it's no aggressive care. So the recent visit of Julie Byrne, she said, I'm worried about the landscape of palliative care in India because it is moving more like an ICU care where the palliative care specialists try to say that you should go for palliative radiotherapy, palliative chemotherapy, and things like that, which is again moving out from the philosophy of palliative care. So there are instances where you can recommend palliative radiation and things, but that's very, very few. But this is a concern, and also as I stand with the main philosophy, and there's a lot of people who also stand with this philosophy, but I can see a shift because of the commercial interest in this whole endeavor.
I'm glad that this is a prophetic voice that needs to be heard. Because sometimes we just lament in silence and we don't allow, it might sound like a voice in the wilderness, like John the Baptist, but that voice must be heard. So that, we can take a term, manipulate its, as you said, try to broaden it simply because you bring profit back into the game. And let us not forget the basic philosophy, which I think is the respect, the dignity, and the holistic aspect that is so at the heart of what you just expressed. Thank you.
Thank you.
When your medical provider says that you need palliative treatment, you kind of feel hopeless that it's the end of life, there's no hope, you're going to die. So does palliative care always means that the patient is going to die?
That's a very moving question, and thank you for asking that. In one of our earlier episodes, we spoke about the fear of dying. And then we reflected on how all of us, in a sense, are living towards our death. Right? And that's one of the myths people tend to have. They say if we start going for palliative care, or if we are asked to go for palliative care, that means it's the beginning of the end. I'd rather look at it a little differently. I'd rather look at it as a way in which once you start going for palliative care, it increases the awareness of the patient as well as awareness of the family in terms of what exactly the disease is all about and how the treatment progression is likely to happen. Because one of the big challenges which we have seen in medical care, and part of it has to do with the culture we are part of as Indians, and you see a lot of it in Asia as well, is this whole concept of collusion between the medical care provider and the family. And what I mean when I say collusion is that very often, in fact, a study was done. In fact, Dr. Carol is one of the authors of that study, and she'll talk more about it in length, is that nearly 37% of patients know what their actual diagnosis is when it comes to a terminal healthcare situation. A vast majority are not even aware that they have a diagnosis which does not have a good prognosis. Right? And palliative care gives you one wonderful platform through which you can talk about the prognosis, you can talk to the family, talk to the patient. Because the moment the prognosis for a patient is not good, it plays a lot on your emotions. There's a lot of uncertainty. There's a lot of fear. And a lot of these emotions are driven by ignorance or lack of sufficient knowledge. And maybe Dr. Carol could speak more about the collusion and the study she did.
Yes, so that was a very interesting study. And why we thought about this study is whenever a cancer or a life-threatening disease happened, the first reaction, the immediate family member comes and says, don't tell to the person. They want to prevent the person from the psychological pain and say that they can't handle it. Tell me. So what happens is that there are many patients who undergo treatment, even chemotherapy, radiation, or even multiple dialysis, where people are not told what is their disease condition. Now, there's a notion that if you know about that you have a serious disorder, that you will die of depression or there is hopelessness. But in our clinical practice, what we have understood is uncertainty is the biggest thing. It is not whether you have disease or you are, that you do not know something is happening to me. I have to go for all these sessions and people are not telling. I'm asking, what is my condition? Everybody says, this is just go for this and you'll be okay. Somehow, and you know that is not right and nobody is telling the truth. So what happened? We designed a study in which actually among our patients, we looked the number of people who actually wanted to know about their diagnosis, but the family members said, you should not tell. And we had to obey that because there's no other way we can, do anything. So that was around 40% of patients, where the patient said, please tell me, they're begging, please tell me, is there something that is seriously wrong with me? And we have to say no. So that was very difficult. So when you think like that, you will think that is it possible even to do like that? But you're coming to home, and the first family member say, at no cost, you should say that person has cancer. If you do that, you will go out from this house. I have to manage this patient. I know he will not or she will not cope up. So at that pressure, you have no other way than to do that. And then we looked into and so there are two aspects. One is the diagnosis. The second is about prognosis, right? How long or how serious it is. Diagnosis is cancer. So this 40% didn't even know the diagnosis. So if I look at the people who didn't know about the prognosis, that would be much more than that. So we looked at the symptom control in these patients, people who know about their disease and who did not know about the disease. So what we found that the symptoms control was almost 16 times better in terms of pain control and even incontinence, everything, breathlessness in the patients whom there was no collusion, where they asked and it was revealed. And they feel that there's a trust among the doctor to the doctor and to the caregivers, and they will tell the truth. If I'm going to die, they'll say that I'm going to die. I can prepare myself, So otherwise it's like, oh, there's a lot of hush-hush going on and I'm not part of the thing. And it's about me. And I know my disease is going bad because my strength is going, many things are happening, but nobody is trusting me to tell me. So what I would say, it is we think that people can't handle. So there was a study even in India. It was and even in abroad, it is almost 30%. So it's not here also. It's there everywhere. And in a study conducted in North India, 98% said that they wanted honest truth in terms of complete clarity about diagnosis and the prognosis, and they feel we will not be distressed. We want to know. and just a few other 3, 4, and there was also a question whether women are weaker and they can't emotionally handle, so the husband should order. So even the studies across the gender, multiple different religions, everywhere it says at least minimum 95% people want to know about, even if they are very old, they want to know if they are going to be their end of life, and they feel that that gives them comfort and trust, rather than a feeling that hopelessness. So just wanted to share these insights.
Yeah, just building on what first John and then Carolin have mentioned, I'd also like to draw into the conversation Michelle, because as a psychologist, these are some of the things that, truth telling. It's not only telling the truth, but how you tell it. How do you break the news? Because from your statistics, it's pretty clear that people want to hear, but we collude, we gather together so as to withhold the truth from them. Maybe you could share something from both your technical expertise as well as your experience, how that could be a way forward, especially when it comes to this aspect.
Yeah, so definitely collusion is something that can be really complicated, and I think it's seen a lot when you have these difficult decisions that you have to make. One of the things that we try and understand is who's really colluding with whom, right? So this is like a secret kind of pact that has been made between, either it could be the doctor and the patient, it could be the caregiver to the patient. It can also be between, patient not wanting family members to know as well, right? So it can happen in these 3 ways, right? So from a psychological standpoint, identifying who's in collusion is the first step, right? Or identifying that this is collusion is one of the first things that we do. We also then try and elicit from whoever it is that is colluding, what is the worst things, or what are some of the fears or the worries that you are experiencing, and try and first reason out there. Because what tends to happen is that we think that the patient must know, right? And I think in my experience of being in the field, the person has to know so that they can make choices. But what the implication of this is something that people don't think about at that point. The second thing is also, is it worthwhile to break this collusion if the person is almost at their end of life? Right? Because telling them they have cancer when they're either gasping or they're in extreme physical discomfort, so they could have pain, they could have symptoms which are not relieved, right, will further aggravate the discomfort or the distress, and the ability to assimilate or process that information is not going to be there as well. So timing of when are we going to address collusion is also something that we look into. So only when we have good enough reasons and we understand that there is some time, and that when we talk about collusion or we try and break it, will this person be able to do something meaningful, with that information, so that the rest of their life can be lived with some, again, dignity, quality, and the choices that they can make are kind of independent to the situation.
Thank you, Michelle. So what she said is very true. So we have 2 different, like individualistic society and a collective society. So we are a collective society. So many of the decisions are not individualistic. It comes as a family. So when we say breaking bad news or telling also, the truth to be told or not to be told is determined again by the patient. So when you talk to them, there is it's not that immediately you're going to say. It takes time, and you have to have enough time, and you gradually also respond to what that person actually wanting to hear. So some people say, I want to know what the disease is. I will come back for the prognosis. So we have to be, it's very personal, and that is how we have to deal with it. But the specific thing that I have mentioned was the patient actually wanting to know, and you tell don't. So that is that is why the symptoms were not at all controlled, because there's a mistrust and something that was happening. But if suppose a 95% said that they would want to, so there is a 5% who do not want to. So what you have to do is, when you do, the palliative care people have the expertise. So when they talk to them, they will have this kind and honest, communication, and also gauge how much the patient wants to know and how much at what sitting. And based on that, you unpack. So that is how, and that comes with an expertise and experience. I just want to add to it.
And this is where I'd like to step in now from the spiritual dimension, because we've looked at it from all the other aspects, because sometimes you can get that kind of a collusion even when it comes to the faith. They'll call you to anoint someone, and it's happened decades ago. He was 92, but don't tell him that you're anointing him with the sacrament. I said, I will anoint him and I will communicate it in my way. Because it's not only what you say, it's how you say it. And people are willing to accept it because, as you said, it through a process or the manner that you just bring it open to them. And that's how we need to, because as I've said on earlier programs, but some things are worth repeating, especially when it comes to the sacrament of anointing. Some still refer to its old name, the last rites or the extreme unction. And so that people are too nervous, too afraid to even think of that reality. But it is so important that you begin to see that this is a sacrament where God intervenes in your life, holding your hand through that pain. If it's grace and God's will, you're healed. But whether or not you're healed, you will be cured, as they say, because God has held your hand till the very end and led you into eternal life. And the sacraments, whether it's viaticum, that's food, Eucharist, communion for the way, or whether it's the anointing of the sick, is always such a tremendous resource. And people are still so hesitant or resistant to what should really be some enormous source of grace and strength, not just by a simple prayer, but very concrete gestures and elements such as oil, which are a symbol of God's tangible, concrete way of communicating that grace. It's not just a prayer up in the wind or in the sky, but it's what you call God becoming flesh, what we call incarnation, touching our lives through that sacrament. Because this is a sacrament of touch. It's a proclamation of the word, but it's also the sacrament of touch, of saying, because that was how Jesus laid his hands on people who came to him to be healed. As I said, ultimately, even, I've said it before, death is the final healing. It's not a defeat for medicine. It's the final healing, because you go back into the hands of God, from whose hands you came in the very first place. You would call it therefore the circle of, not only of circle of life, but the circle of eternal and everlasting life. And to see how this dimension should not be kept aside, that collusion should not take place even there. It, as you rightly pointed out, with the experience, with the sensitivity to the patient, because as Michelle pointed out, to find out where they are at rather than what you're going to offload onto them, is to accompany, to journey with them precisely to that, so that it will truly be, this sacrament will be part of the palliative care, the holistic dimension with which we began this whole presentation. So I think we've discovered different angles which we should, to give weight to what we are talking about when it comes to palliative care. Dr. Carolin, in a previous episode, we've looked at advanced healthcare directives, especially in that series on conversation with the dying. Now, advanced healthcare directives serve a number of purposes. Now, given the context that we are talking particularly of palliative care, how can this be introduced or woven into such care so that it'll be of great help, not just in a moment of emergency, but something that you think of long before you cross the bridge when you come to it?
And thank you, Father Juvi. That's a very, very important question. And I think palliative care, you cannot complete the palliative care discussions without this advanced care directive. So what it is, as we said, like the palliative care team having continuous discussion about the disease progression, and it prepares people in terms of the person who is progressing in his disease, and also the family members who are involved. So after some time, there is also a discussion regarding So medical emergencies, how the last stages be and where the person want to be. So one of the things that most people say that going into the hospital is not a preferred destination for most people. The ICUs have this monitor sound and it's very distressing, you know, and somebody else is passing away and their family members, somebody is taking them to mortuary, all those things. So even if you are half alert, these are the things which feed into your subconscious mind, and most people are terrified at that space where they say it's a cold place. It's a place where surrounded by people whom they do not know, and then only the monitors make the sound, no conversation sound, and then it's only cries and different people whom they have no idea comes and does things for you. And at any moment, you feel that there's no control because you can't tell anything to people who come for, like, it's not your son or a daughter who can, I say I need water or anything, or somebody suddenly comes and decide to intubate you or do act certain actions on behalf of you, So they feel that this is not a right place where I want to be in the last phase of life. Everybody sort of, most people, think of them in their comfortable space, usual their room, their preferred, where if it's facing the window, and then people whom they know. So and conversing with them and slowly sinking in. This is what most people decide. So what happens is that there may be children and immediate other family spouse. So they may not agree at that time because saying that, what if it may not be sinking, we should do something more. I want to see you another 3 day more or another 4 day more. So there can be tense discussions over it because sometimes they say that maybe you're not having hope. What if we want to have you more? So there are conversations like that. So it takes some time for everybody to agree and say that, yes, this is this person's wish, and there, you can write it like, so a doctor, like a family doctor or a palliative care doctor and an attorney, and you in the presence of the family member being the witness can make an actual will saying that in the event of certain casualties, I don't want to be put in aggressive care in terms of ICU. Some people even say that if it's more than 3 days, there are times it's entirely based on person's wish that they make a decision. So this is very important because if people go to that stage without making this decision or having this conversation, we have seen that lot of distress because there may be like 2 people who are here, 1 person may be abroad, like those kind of things. So, the conversation becomes like, money is not the issue. Just do whatever we can. But the people who are here may say that it's not about money or not money. We feel that the person is suffering. But at that point, the person is, we do not know the person's wish, right? So both will argue and say that is truth, And usually medical professions don't take it. They have to come with a consensus. And if not, it's the aggressive care. That's the usual way because, you need families' consent for all these things. So this advanced care directive is very, very important when you're talking about palliative care.
Thank you for bringing that element because it needs to be at least articulated and put down. People might say word of mouth, but the larger family, if they are not aware of it, there can be tremendous conflicts. And the one who suffers, if that person is still aware and conscious, is the patient themselves. Sometimes the siblings will have a quarrel among themselves. I'm the only one on whom the burden falls. Where are you? Yes. So you play the victim and the martyr. Okay, it's true that sometimes people who are far away will give all sorts of great advice, but won't lift a finger. Or if they come, they just come for 5 days, create a big scene and then go off. So there are a lot of family dynamics at play when it comes to these. And what happens is this is then thrown into the face of the patient. I'm doing so much for you. What about the other brothers and sisters? And this drama, sadly, is played out in so many families. And that's only an initial part which is going to get full blown when this person dies, because then they're out with their knives because property is to be divided. So I think we cannot avoid all conflict, we cannot avoid all disagreement, but having something as concrete as that, as spelling it out in an advanced care directive, will certainly go some part in respecting the autonomy and the dignity of the person who's under treatment, but also at least smoothens out some obstacles that could already be existing in complex family dynamics, which then get out into a really big fight. So thank you for bringing out that element as well.
It also brings one responsibility, like, the conversations, these are conversations we usually avoid, but, you should be open to these discussions, and also, your spouse, your children, or your elderly parents, in terms of children means if they're adults, in terms of, you should know their wishes, right? Because, like, I should know, like, what he would prefer, and he should know at least that much, because even if you, at a moment, you have to take a decision, then you should be confident, and you should not be living with guilt. So that's an important question. Sometimes we think as a theoretical thing, but practically, do we know what our mother needs? Do we know what my husband needs? So these are the questions that we should ask ourselves, is something which I want to emphasize.
Thank you. And this can never be emphasized enough because sadly this is a reality across all cultures, countries, faiths, all people. And I think I'm glad what we are offering here is a conversation so that more and more people will be able to address it. There has been mention earlier of home care. Now this can open a vast possibilities, but I'm sure there are specifics that perhaps maybe you could throw light on, because there are specific conditions in how it could be manageable at home. Maybe give us some insights into that.
Well, thank you, Father Juvi. So that's a very important question. One of the main, again, it's the philosophy. Sometimes when we think that we want to give care to our loved ones at home, we are thinking that we have to construct a hospital, right? It has to make, like, everything that is provided in the hospital has to be given at home. Now, the whole aspect is that why we are bringing the person from the hospital is that it's not ideal. You don't want to put so many aggressive. That is the basic premise by which we are bringing the person from the hospital. So there are only few things which we need to take care. One is the basic comfort. So the mattresses, some people you require, air beds or water beds. Somebody should change their positions, because most people have not much of muscle mass or subcutaneous fat. So what happens is that same position will have big bed sores, and the quality of life becomes very bad, because it will never heal, because the disease is progressed, and it can have smell and things like that. So that is one thing. So the basic. Then the next thing is feeding. People have big concern about feeding, how to feed if a person is bedridden. So there are propped up positions where the certain specialized type of beds where you can put the head elevated. So that will help the person from, prevent them from choking. And another thing is the question of Ryle's tube. There are people who say that they are not eating anything, drinking anything. So should we have the Ryle's tube? So most people hate Ryle's tube. And again, what are we trying to do with this nutrition here? We have to allow people to actually pass away peacefully. That is the philosophy. Adding, so earlier times, how people used to pass away. It's not that people are dying now, right? We all have memories of people who are elderly or somebody passing away peacefully at home. It is not a very distress or somebody. There are last days people stop eating. Maybe just ask only people, give a spoon of water and things like that, and we're completely okay with it. So, the thing is, there's no forcing, tubes. It is uncomfortable. Then again, if there are some distressing symptoms, like one is pain. pain has to be completely controlled. There is no question to it, and a good palliative care would give you advice. And earlier also I said, but I'm again emphasizing 90%, 99% of the most pains can be controlled. Michelle earlier said depression is another thing where people are not able to cope with it. Sometimes we prescribe, and it is needed also to calm their mind. So antidepressives, if required, we will add. Some people require mild sedation because they're not able to sleep, because towards the end your hormones and everything is getting, so you have to give some medications. Then breathlessness. So breathlessness, simple nebulization, which just expands your lung, and also in terms of sometimes moving the person closer to the window, even just a fresh bout of air that actually relieves a lot of things. Then wounds also can be managed at home by dressing. The family members can do that. And the pain medication. So some questions are like, do we need a nurse? If there is a family member can do whatever a nurse can do, because at that point we are not thinking of IV injection or IM injection or a subcutaneous or a drip or anything. That is not required. So what is maximum for pain relief? You can have a subcutaneous thing that will be open for for 2 weeks. So you can they just have to take the measured thing and give it. So then oxygen. There's also a question about oxygen concentrators and all. The studies have shown that adding oxygen is not of any additional benefit, but some people feels that, okay, some people say that they want to have, in those cases, oxygen concentrators, that is 2 to 4 liters, not more than that. More than that would be uncomfortable, no need for cylinders and all. Now this is general, it's a simplified care that you are thinking, and that's most comforting. That's the most, and the more you add gadgets, the more you add invasive ways, you defeat the purpose of palliative care and add distressing symptom to the patient. In terms of certain specific conditions, if you have a lung condition, then you may need oxygen more. That's a different condition. If there's from the very beginning, they will be associated with that kind of a dependence. But other than that, it is mostly, a very simple care at home.
Thank you for spelling it out in quite a number of aspects that make it so practical, pragmatic. In a certain sense, where we've looked at the Church's moral teaching earlier, where we spoke about, especially in cases where instead of prolonging death,
yes,
we do not actively in any way promote euthanasia. I hope that is clear. Yes. The requirement of hydration and nutrition continues. But to actively, that is certainly is not what we are talking about, and I want to make that absolutely clear. But the other things are so workable, cost reducing,
yes,
and giving you this whole benefit of being really in a family situation around. It could also be a time of great bonding, because and see the loved one see that all of them around you at that moment is really a comforting aspect. This is part of the palliative care.
Father, I just wanted to add to that, because you brought the theme of euthanasia. So when people are not eating and drinking, see, they are telling you, I am ready to go. I just want to slowly ease out things and allow me to do that. And when you do this invasive, you're saying, I will not allow you. There's a rebellion. It's not the natural thing. So what are we trying to do here in terms of, you are not allowing person to die peacefully by saying that I will give you this, but the person has decided that I want to sink in. So that is why it is not euthanasia. It is allowing a person to peacefully navigate, and death is a reality, as you rightly said. And one of the things at that time people ask is, there's a need for reconciliation. They ask for people they have not spoken to for a long time, or they say, I want to say this to somebody, I want to see a priest, I want to call this son, which I was not talking for like 15 years. And also they start telling about, I don't think I have lived a good life. I have certain things which I want to talk to somebody. I want to reconcile. I want to have forgiveness with God. So this is something, that time people, they're not worried about food. They're not worried about oxygen. They're not worried about, they really want to have peace with these aspects. So I think you may be able to elaborate on this, but this is what we feel, we see.
I think you've dovetailed this into this whole dimension of the spiritual dimension that comes to us so strongly towards the end of life. I've shared this incident of Father Edward Cleary before, because when he was told that he had cancer and did not have much time to live, and I had these long conversations with him, and one day I asked him, what does it feel to know that you have this ailment and you're literally in the shadow of death? And he said, this is a special grace. And I said, what do you mean? He says, tell me how many people have time to prepare. And he saw that really as a time, as you rightly put, as you come to the end of your life, to be at peace with oneself, to be at peace with others, to be at peace with God. And this is something that we must really understand. So when people are asking them to accompany them, we can give medication to deal with their physical pain. We can give them sedation when their mind is disturbed. But we also need to give them the spiritual dimension, because to ease that pain, which no medication can ever address. It may relieve the physical symptoms, but that's only for a time until we have dealt with the deeper issues. And this is something that is so crucial. Sometimes some people will prolong their death till that person whom they want to see or to be reconciled is like they have not given themselves permission to die.
Yes, that's very true.
And so it is so important, and I cannot stress this enough, because as a pastor, as a priest, I've seen homes and families where they're even fighting and resisting on their deathbed. Or people are saying the harshest things, insensitive things when a person is dying. I think the death of someone should be a moment also of grace. It should be life-giving for others. We speak about the redeeming aspects of death. And I think that's one thing, that somebody's death makes us question our life, because if tomorrow I die, will I be at peace? Sometimes our conflicts are taken on and on, but death relativizes everything. Death relativizes our degree and our pedigree. I come from this, I come from that. Makes no difference when you're dead. Death relativizes our possessions and our positions and titles we hold. You can't take that to the grave. Yes. Death relativizes everything except love. Because where there is love, you care. And we care because we care about the one we love. And therefore, it is so important to understand the role, as you pointed out, but across faiths, is the role of forgiveness. Although we've said it before, I think this is something that we need to hear, because many people just hear it and let it pass. For this reason, that was almost one of the centerpieces of Jesus' prayer on forgiveness. Because he knew we needed it not only physically, emotionally, we needed it spiritually, to be integral. Holiness is not just my piety, my religiosity, or my empty spirituality. Holiness is to being at peace with God, with others, and with myself. And therefore, so much of what we call is the letting go is important. The letting go is something that is easier said than done. I read a beautiful writing by Henry Nouwen, a wonderful Dutch priest who was living in the States, in North America. He's written books like The Wounded Healer. And he gives this marvelous example in Germany of a trapeze artist in a circus. And the trapeze artist was the one who goes and just leaps into the hands of the catcher. And he makes that powerful distinction between the flyer, the trapeze artist, and the catcher, the one who just holds you. And he says, the trapeze artist, the one who's flying and going in that direction, has to do nothing. He just puts out his hand and the catcher is the one who holds it. If this person goes to try it, the wrist will break, they'll slip, they'll fall. The only role is to let go and to allow your hands to be grabbed. And he gives that as a beautiful example, I think, of letting go. We refuse to let go because we want to be in control. Why did he say this to me? Why did she do this to me? And we grow old as bitter people. It's only when we realize this is not worth it. We fight for property, we fight for name, we fight for position, we fight for, do you know who I am? Does that really matter? Does that really matter is the question. And that is why part of what we are looking at palliative care, we've looked at it from different dimensions, but I cannot insist on this enough. I'd like to really bring into this whole element of the centrality of Jesus. Now, he died young, he didn't die of old age. But he was murdered, he was assassinated. And together with the physical wounds at his death, there were also emotional wounds. Imagine the people that he chose, handpicked. One of them denied, another betrayed, and all but one abandoned him. They were all gone. So together with the physical pain, on his deathbed, which is the cross, there was also this emotional and spiritual pain. I mean, I've taught these guys, I've educated them, I've instructed them, and is that also a failure? So much so, in his depth of his says, my God, why have you abandoned me? He's quoting from a psalm which interestingly ends with great hope, and those who know the psalm know how it's going to end. But why is Jesus going through all of this? The very fact that he chose to become human, so that no longer can we say, does God not know what I'm going through? All the pain and the suffering and the difficulties that he embraced it all. So we can say, yes, we know a God who knows what it is all about. His name is Emmanuel, God with us. Not Upparwala, not upstairs, not far away, not distant. But he knows our reality from inside our skin. So that when time comes for us to embrace the cross, we'll know that he will not abandon us. He realized the power of forgiveness. That's why from the cross he said, Father, forgive them, for we know not what to do. And I would therefore appeal that this element of forgiveness should be so central as to all parts of our life, but it comes with an absolute urgency and immediacy, especially as we come to our ending days. But let's not wait for that. Don't wait for the 11th hour. As the poster says, you may die at 10:30. So I think it is to know how important it was for Jesus, who identified with all those people who will one day face the reality of death. But he did it with dignity and grace. Now you will say, what dignity? I mean, they stripped him. Technically on the cross he was naked. Imagine standing in front of that. So the dignity was not lost in spite of the excruciating circumstances of his death. The dignity is not lost even when you need somebody to change you, to bathe you. No, the dignity is not lost. The dignity is there because Jesus showed, even in spite of it all, he made his dignity really manifest. And there we remember Mary talking about palliative care. Because when somebody's sick, we like to wipe their fevered brow. We like to just, the cheek, some saliva is coming down. Can you imagine us standing at the foot of the cross? Okay, how she would have liked to take off the thorns piercing her son's head. How she would like to ease the hurting wounds. And all she could do was just stand at the foot of the cross. It seems she did nothing. But actually, just by standing, she did everything. And that's what part of the palliative care. There are times you feel so helpless to see your loved one just fading away. You seem helpless because no medicine is able to help. We feel helpless because in desperation, you can't respond to the person whose life is just fading in front of you. At those moments, words are not necessary. Words can be too cheap sometimes. All you can do is just hold the hand and stand by them, just as Mary did. And that is really the power of the spiritual strength that we speak about. Sometimes we are all too content with living our faith in a very cultural way, not connected with the deeper aspects of our life-giving faith. And therefore, even a sickness and finally death is an invitation for us to discover the deep spiritual resources of the face of Jesus, who knew what the suffering was, to therefore draw us into that love. And therefore, just as we've highlighted all the other dimensions, the physical, the psychological, the emotional and the social, we must never leave out of this equation the spiritual, because that is where it brings holistically all of it together to be embraced in God's loving care. Because I can never cease repeating, ultimately, we go back into the hands of God, the loving Creator God who made us, and we go back into His arms and to His loving embrace. And that is a grace that we can all pray for and open our hearts for and to live by. That, I would think, is holistic indeed.
Yes, yes, very nicely said, Father.
Dr. John, we've been talking about how this palliative care really addresses particularly the needs of the person involved, aged, sick. But what about the family? I mean, how do we bring that into the equation? How does it benefit them as well?
Another very important aspect, again, we spoke about briefly, was dying in an intensive care unit is a very sad way to go, right? Because you're in the middle of machines. Not only is the place physically cold, but it's very, very emotionally cold. Despite the best efforts of the healthcare people working at these intensive care units to provide humane care.
First of all, it was an intense thing. Now that intense thing is not there. So first there's an emptiness, because the entire thing was surrounded, and the whole thing was about this intense emotion about this person's care, and everybody was adjusting to that, and so that they attach meaning to that, right? So suddenly that person is no more. So there is a feeling of, what is it like, an emptiness. Within few days, they start thinking about all the good things that happened in terms of how great that closure was, and they start so that's why having a palliative care, the almost 99% of the cases, a good death where your memories are like talking, laughing, allowing them, and sleeping and going without any distress. So that is the last closure memory about that person. In terms of another challenge that we face is, insurance will give you insurance when you're healthy. The moment you have into really stage 3 and stage 4 cancer, or on dialysis or multiple organ failure, the premiums are going to be high, and most times they would just say that their panel of doctors will not approve the insurance.
Thanks for joining us for yet another part of this episode on palliative care. But again, don't forget to like, share and subscribe, and even more, pass it on to others. So for now, signing off from Aging Gracefully, a talk show for evergreen.